Welcome to AETCM. Shall I start, sir?
Yes.
A 58-year-old male patient presented to emergency department with complaints of altered sensorium for 1 day, increased drowsiness for 12 hours, and irrelevant speech for 1 day. On initial assessment, airway is patent, slurred speech but able to maintain airway. Breathing, respiratory rate is 20 per minute, saturation 97% on room air, and bilateral vesicular breath sounds. Circulation wise, pulse 92 per minute, regular, BP 110/70, capillary refill time is less than 2 seconds, and no active bleeding. Disability GCS 12/50 only, E3, V4, and M5. Disorientation to time and place, asterisk is present, and no focal neural deficits. Pearl and GRBS is 120. Exposure, icterus present, pedal edema is present, ascites present, no signs of trauma or afebrile. History of presenting illness, patient was apparently well until 1 day prior to presentation when he developed confusion and inappropriate speech. Family members noticed decreased interaction and disorientation to time and place. Over the last 12 hours, he became progressively drowsy and less responsive. History of constipation, 3 days. And no history of fever, seizures, head trauma, focal weakness, vomiting, or recent alcohol binge. No similar episodes in past 6 months. So, past history when we did non-case of CLD is there. Alcohol-related cirrhosis, 5 years. Multiple prior hospital admissions for ascites. No history of any intracranial diseases. Drug history-wise, patient is on spironolactone, furosemide, lactulose. Irregular compliance is there. Personal history, chronic alcohol intake for 20 years. But for the last 6 months, he has not been on any alcohol. Non-smoker, poor dietary intake. Family history, no family history of liver disease, no history of neurological disorders. Allergy history, no known drug allergies. So on general examination, patient is drowsy but arousable. Also there is
What is your clinical diagnosis?
hepatic encephalopathy, sir.
Grade?
Grade 2 because flaps were present for this patient.
What are the grades of hepatic encephalopathy?
There are 4 grades. Grade 1, patient is having patient is almost normal, but some confusion is there.
We are confused.
Sleep
Altered
pattern is
Grade 1 is altered sleep rhythm. Grade 2 is
lethargy.
mild confusion. Grade 3 is plus
Stupor.
Grade 3 is stupor. Okay.
And grade 4 is coma.
So this patient is currently in grade 3. 2.
So mild confusion and
Flapping
tremors are there.
Okay.
So yeah, and on systemic wise examination, CVS S1 S2, respiratory wise bilateral air entry is present, no crabs. Parabdomen is distended, shifting dullness is present, mild sphenomenon.
What are you looking in the CVS, RS, and the CNS in this type of cases?
So parabdomen,
you know that ascites
CNS
can
we
be
have to look the grading GCS
you have
level.
to look for the GCS and people important or not?
Yes, sir.
Why?
React.
CLD might have thrombocytopenia.
Bleeding. So bleeding is there is a high chance of bleeding. So pupil asymmetry is very important.
Okay.
Then CVS.
CVS. Heart.
If we know only, you look for that. That's why I am telling. CVS.
Hepatic effusion.
Pericardial effusion. Hepatic effusion in heart. Pericardial effusion. Pericardial effusion can be there. So you may get a muffled sound. Lungs.
Lungs, respiratory alkalosis,
Pleural effusion. Pleural effusion. So we have to look for specific things, and only you'll get it. If you blindly see lungs, you may not get anything. So pleural effusion is the commonest cause. Left or right?
Right.
Or left?
Right.
Right is the classical finding. So you have to look for all these things. No need to examine the lung full. Most of the time you get right-sided pleural effusion. Some patients will have pneumonia. Aspiration pneumonias are very common.
Then we did our point of care, sir. In point of care, hemoglobin level was 11.2, total count 12,800, CRP around 24.
So what will you suspect? Counts are slightly elevated, hemoglobin is slightly low.
So,
What are things you will suspect?
We have to look for any
You are
infection.
blindly investigating a case. You
Yeah.
are not seeing whether it is useful or not.
No, we are looking for
Counts are
it.
12,000.
Infective pathology.
So you have to suspect a infective pathology, especially SPP.
Yes.
Hemoglobin is slightly low.
Yes.
What will you suspect?
Hemoglobin is
Hemoglobin is slightly low. What will you suspect?
And
GA
J
bleed.
bleed.
So these are normal thinking only, not
Ah.
extra. This one. So normally we suspect a small bleed. Okay, then platelets.
Platelets around 68,000. So
What will you suspect?
Splenomegaly.
Splenomegaly indicates portal hypertension.
Yes.
Okay, so these all are indirect evidence of the disease. So portal hypertension or infection might have triggered the thrombocytopenia.
Then on VBG wise, respiratory alkalosis was there.
EBG wise respiratory alkalosis.
No, sorry, ABG wise. ABG wise.
ABG wise respiratory alkalosis. Why respiratory alkalosis? What will you suspect there?
So patient is a little bit disoriented and because of the hepatic
effusion or infection, acute infection, aspiration. Will you suspect pulmonary embolism in this patient?
No.
Why? Is it a thrombophilic condition? CLD?
No.
Sure. What will happen to coagulation? Coagulation proteins?
INR will be
elevated. So normally they don't develop pulmonary embolism.
Chances is, but
no chance. No chance. Eh? Less chance. So you have to read about all these things. Okay, anyway, I'm not telling this patient, but you have to read what is the chance of pulmonary embolism in this type of patients. Okay.
Then we came, USG was done, which showed cirrhotic liver with ascites. CT brain also was done side by to rule out any intracranial pathology. No intracranial pathology was there. No bleeding was there. So we came to a diagnosis of hepatic encephalopathy, grade 2.
Any brain edema was there in this patient?
No, sir.
There was no brain edema.
No brain edema. So first line we have to give lactulose as first line because patient.
So this patient is admitted in ER. How do you give lactulose?
So we can either give it as a syrup or we can give through rectal route.
What is that rectal route?
Enema.
Lactose retention enema.
Yes.
Okay.
So around 300 to 700 ml in distilled water we can give enema. Then we can either start, if we are admitting, we can either start on.
If the patient is diabetic, can you give lactose? It is sugar, no? It is a sugar solution.
Yes.
The patient is diabetic, high sugars are there. Can you give lactose?
Yes, we have to.
Yes, it's a
disaccharide.
It's a non-absorbable sugar. The answer should be very clear. So you can give. There is no problem at all. Then after lactose.
Then rifaximin we have to give 400. Yeah. 400 mg TID or 550 mg BD we can give.
What strength is available?
550 and 400 both are available.
550 is available. Huh? 400 is available. 550 is available. I don't think so. Huh? It is there. Okay.
Then we can also give flumazenil, benzodiazepine.
Okay.
Antagonist we can give. Then mannitol also is if there is any cerebral edema but not in renal failure patients. So these are the treatment for hepatic encephalopathy. Then for diagnosis of.
And this is not over. So if you are admitting this patient in ICU, you take care of other things also. No, so you have given initial 3 drugs, lactose. What else you told? Rifaximin and flumazenil. Okay. And what else you have to give?
Then we have to look for any electrolyte abnormalities.
Which electrolyte abnormality?
Hypokalemia.
What was the potassium in this patient?
Potassium was around 4.2.
Nothing to worry. Leave that. Sodium?
Sodium was around 130.
130. So maybe slightly dilution. Then what else?
Then we have to look for GI bleed, anemic or
GI bleed. Look
yes.
for GI bleed. Okay.
That also was not there.
Hmm.
Then we have to look for hypodehydration.
What else you do? Sugar monitoring. Sugar monitoring is very important. This patient can go to hypoglycemia. What else? Huh?
Creatine levels, kidney.
Is there she is telling if there is an infection, you have to start antibiotic. So antibiotics are must. Most of these patients, they can have some infection or SBP can be there. So better to start on antibiotic and search for infection. Okay. What antibiotic normally give? SBP prevention.
SBP, cefotaxime, third generation.
Third generation supply. What is a common organism?
Common organism.
E. coli. E. coli is the most common organism. So use cefotaxime or ceftriaxone. Okay.
Then the diagnosis
water. Water restriction. Should we advise water restriction?
Yeah, ascites is there.
If ascites is there, then water restriction has to be there. Yeah. Then sodium.
Sodium, you have to monitor if the levels are dilutional, the levels are going.
What is the advice on sodium in a patient who is having ascites, pedal edema? Is this patient is having ascites, pedal edema? We are treating only portal hypertension, but how do you advise salt in this patient? Normal salt. Huh? No added salts. But if you give salt, what will happen? More salt if you give, what will happen? More water retention can happen. Okay, so better to avoid that. Then protein.
Protein should be decreased. Protein.
Animal protein should be avoided. Plant protein should be restricted in initial phase of hepatic encephalopathy. Once the patient recovers from hepatic encephalopathy, you can start
on proteins.
Thiamine.
Alcohol.
Is he alcoholic?
No, for the past 6 months he is not alcoholic. Thiamine is not good. Then we have to, if there is any drugs, sedatives, tranquilizers like that, we have to stop that drug, offending drugs.
Okay.
That's diagnosis.
What happened to this patient afterwards?
Patient improved sensorium after giving loose enema after passing some stool, and patient was admitted under gastromedicine for further evaluation.
Okay.
Monitoring and all.
So as an emergency doctor, what all things you are looking here?
We have to rule out the major cause, like constipation was the triggering factor here.
Here, constipation was the trigger.
Yeah. Otherwise, if there is any GI bleed, we have to do for that, or if there is any electrolyte abnormality.
If there is a GI bleed, how do it affect hepatic encephalopathy?
So bleed when protein, blood is protein, increase protein
intake and produce ammonia production. Yes.
Then electrolyte abnormalities we have to correct it.
Reversible cause of hepatic encephalopathy. What are reversible causes?
GI bleed.
GI bleed.
Constipation. Electrolyte abnormalities.
Hypokalemia.
Then hypovolemia.
Dehydration.
Then if any drugs, tranquilizers, sedatives.
One thing you are always missing.
Hypoglycemia. Infection.
Infection is the most common cause for hepatic encephalopathy. Should never miss it. So you have to start antibiotic and then you search for any sort of infection that is not there. You can stop it. There is nothing wrong in that, because they will not have a response like a normal person. Suppose when you get infection, you get fever, high degree fever, chills, rigors, and all because of your immunity is good.
Yes.
For them, there is no immunity. For oncology patients, liver disease patients, renal patients, they may not have any signs of infection. That is the most important. So, but counts are little higher here.
Yes.
That's why. How do you rule out SBP?
So SBP, there is a criteria for SBP. So WBC count should be more than 1000, or bacteria on gram stain, or PMN leukocyte more than 250 per ml. Okay. So that is a criteria, and the drug is cefotaxime or third generation cephalosporin.
Okay. What else you want to tell?
Then Underlying cause of hepatic encephalopathy, as we told, GI bleed, electrolyte abnormalities, dehydration, hypovolemia, acute or chronic kidney injury also can cause. Then infections.
How do kidney injury occurs in this chronic liver patient? What are the reasons for renal failure in this type of patients? First is hepatorenal syndrome. Last is hepatorenal. Whatever cause you told about hepatic encephalopathy triggers, no, they all produce renal failure also. Once you rule out everything, if creatinine is elevated, then you have to suspect hepatorenal syndrome. Hepatorenal syndrome is a terminal event, so it is not reversible. So you have to rule out other reversible causes. Then, if the creatinine is persistently elevated, then you have to suspect HRS. So never tell HRS first. Suppose the patient is having severe intravascular volume loss, that itself can produce renal failure. An ascites patient can have intravascular volume loss.
Yes.
So if you remove large amount of ascites fluid, what will happen? Hypotension. Fluid will shift from the intravascular compartment to this third space. Yes. So suddenly there will be deficiency in the intravascular compartment. They all go to renal failure. If the patient is having severe bleed, again they'll develop renal failure. If there is an infection, they can have renal failure. Okay. What else you want to tell?
Then, so there is two types of hepatic encephalopathy: covert and overt. Covert means minimal hepatic encephalopathy or grade 1.
Okay.
From grade 2 onwards is overt hepatic encephalopathy.
Okay. Okay. Anything else you want to add? Nothing. Okay. Thank you.